Hey, everybody. We're going to get started now. My name's Eileen Alasso. I'm welcoming everybody here to the Zoom educational meeting today. We're going to talk about stroke. I've been here at Salem Hospital for about 8 or 9 years now, and I've focused primarily on stroke and neurology. I'm a nurse practitioner, and I've specialized in neuro since like 2005. So I kind of have a lot of experience under my belt here. So today I want to talk about quality care for the stroke patient. And I'm going to give you a whole lot of information, but I'm also going to throw in some quizzes and a couple of case studies to get us thinking about what we need to do when we see stroke patients. And they're not quizzes that I'm going to test you on, it's just a couple of questions, and I'll give you the answers at the next slide. I won't advance. Right, so this is a CEU program, so we have some learning objectives. I'm going to tell you a little bit about the stroke statistics and the definition of stroke and the different kinds. I'm going to learn about the diagnosis and the workup of stroke and TIA patients, principles of nursing management and why it's so important, and then describe sudden onset of new symptoms and what to do in those scenarios. Stroke facts, I put a lot of information here because I only wanted to give it one slide because it's just overwhelming. Stroke is a very prevalent event that happens that causes a lot of disability. Almost 800,000 people a year have strokes, and that was information back from 2020. About 142,000 people died of stroke in 2020. Seeing stroke currently going up during COVID, that seems to have elevated people's risk factors for stroke. So I don't know what the numbers are going to become over the next few years, but just something to keep in mind. Stroke is the #1 cause of disability in the United States, and because COVID has kind of messed up a lot of the statistics, stroke has actually dropped down to the 5th leading cause of death. It used to be, was trying to get between 3 and 4 with cancer and hypertension as causes of death. And we've also seen a dramatic increase in the number of young people hospitalized with stroke. And they're attributing that to risk factors of obesity and smoking, especially among the younger population. And, with all the diversity and equality issues coming into play now, we're also looking at that, and we're finding out that Blacks and have the highest rate of deaths due to stroke, and we can attribute that to a lot of the racial disparities that they're experiencing. And we've also noticed that even though the percentage of strokes in those populations have remained the same for the Blacks, the percentages of strokes in Hispanic people have increased since 2013. And stroke is extremely costly to our healthcare system and in our economy, and it accounts for nearly $53 billion in costs per year. This is something that if the nurse at an individual patient level can impact and create a less of a burden to the patient, it'll be a less of a burden to society also. I'm going to talk about 3 types of stroke today. The transient ischemic attack, which a lot of lay people refer to as mini strokes. Hemorrhagic strokes, which account for 13% of strokes, and the ischemic stroke, which account for 87%. hemorrhagic strokes are caused primarily by hypertension, and a lot of times this causes rupture in an aneurysm or some kind of malformation in the vessels in the brain, or ischemic strokes are usually attributed to people having a lot of risk factors, and we'll review the risk factors further on in this presentation. If anybody has any questions, for those on video, you can type them in the chat. Jen is monitoring the chat, and she'll let me know people who have questions. And if anybody here has questions, just raise your hand and I'll answer them. And I'll repeat the questions before I answer them so people online will know what the question was. So the first stroke I want to talk about is a TIA, or a mini stroke, and this is used caused by some type of ischemia that has occurred within the brain. So something in the flow of the blood to brain cells has been compromised, and the brain has responded to that. The cells haven't actually died, they've just gotten kind of stunned, and they're giving you a warning signal saying, hey, listen, something can happen here. I'm trying it out to see what can happen. I like to tell people, especially in the community, like to think of the TIAs as time bomb in action, and that gives it a little bit more significance and importance to those who I'm talking to. And when patients are admitted to the hospital for a TIA, they're treated initially as a stroke and worked up as a stroke because it potentially could be a stroke. We know that stroke occurs in TIA patients in 2 to 5 days if they have high risk factors, significantly, like 45% of the time, if they have enough risk factors. So we really want to make sure we get ahead of this and get them on some kind of preventative treatment before they actually do have a stroke. So my first question is, you're formulating a teaching plan for a client who has just experienced a TIA. Looking at the answers below, which facts do you think are really important in including in that plan for the patient? And the answer is A. We know that they can have a stroke in the near future, so we want to emphasize that, so they'll take proactive steps to prevent it. TIA symptoms, if they last longer than 24 hours, you're either going to see some cellular damage on an MRI, which means it actually had a stroke, or it's going to be another cause. And people can have lots of reasons why they have stroke symptoms. They can have an old stroke and a UTI, and because of the stress on the brain, the old symptoms come back into play. They can have encephalopathy, which will mimic stroke symptoms. They can have seizures, which can mimic stroke symptoms. So you want to make sure that you know what's going on. So the MRI is a bit more definitive in defining the stroke. And we don't have any research telling us what the most common symptom of stroke is, of a TIA is. So that's thrown in as a trick answer. Any questions on TIA? All right. The next stroke I want to talk about is the hemorrhagic stroke. And that's when a blood vessel actually ruptures inside the brain. So there could be multiple symptoms of this. So you can have the same symptoms as you would have an ischemic stroke, where just a small area of the brain seems to be affected. But in addition, you can have a painful headache. Usually a painful headache is not associated with an ischemic stroke. You get the pain with the hemorrhagic stroke because there's blood, which is an irritant, and in the brain it's very irritating. So people get like really bad headaches, they get neck pain, and then they have symptoms of which are more globally in the brain, because the brain, instead of just being a few cells being impacted, the brain is actually kind of getting squished, and where the brain cells are, where the blood is, they're irritated and they're just reacting like mishmashy and firing off kinds of abnormal signals. So they can have nausea and vomiting from the increased pressure on the brain, and a hallmark of a hemorrhagic stroke is a decreased level of consciousness. If a patient comes into the emergency room with any of the symptoms of a stroke, or if you're on the floor and you come upon a patient who has symptoms of stroke, you always want to call a code stroke standby or in the ED a code stroke. The diagnostic test for this is a head CT. Head CT will be negative in ischemic stroke because there hasn't been enough time for the damage to show up on the imaging. But on a plain head CT, blood will show up right away as bright. So it's very definitive for a stroke. Because this is a code stroke situation, there'll be a teleneurology consult, and the treatment for Salem Hospital is to transfer them to a higher level of care. Whenever a patient has a hemorrhagic stroke, you always want to make sure neurosurgery is available because these patients can decompensate extremely quickly and require surgical intervention. And we don't have neurosurgeons that deal with the brain at Salem Hospital. We actually have transfer agreements with 7 or 8 hospitals in the area who will take our patients within 2 hours of a diagnosis of a hemorrhagic stroke. So and the doctors are real familiar and the ICU staff about, who to call. There are numbers posted, appropriate places, and just to move them along. If they're in the ED, as soon as they see the positive head CT, will start calling other emergency departments to have them transferred to the emergency department, and it will be an ED to ED transfer. Another quiz question. So, about again, the hemorrhagic stroke, what assessment data would indicate to the nurse if a client would be at risk for a hemorrhagic stroke? Answer is a high blood pressure. That's the predominant risk factor for a hemorrhagic stroke. Blood pressure causes a vessel in the brain to rupture because it just doesn't have the, usually it's an aneurysm, so there's some weakened wall where the aneurysm is, and it just doesn't have the resiliency to deal with the blood pressure. When they talk about a bruit in the carotid artery, that's usually atherosclerotic plaque that's building up. So there's a swishing sound when the blood tries to flow through, and that's atherosclerosis, so that doesn't cause a stroke. High glucose is a risk factor for ischemic stroke, and cancer is not a risk factor for stroke. So I'm going to review a case study. So we have a 68-year-old black male admitted with a right ankle fracture after a mechanical fall. So he's being admitted for his fracture and nothing else. He has a history of an MI, hypertension, hyperlipidemia, and smoking. And per the patient, his pain is under good control. So on the first morning after he gets admitted to the hospital, he reports to his nurse he has a really severe headache, he has nausea, and he had some right arm weakness. And you do your assessment, you check his vitals, he has a blood pressure of 210 over 114. You do his neuro assessment, you also notice that he's complaining of the headache and he has some weakness. So I just want to ask people, what do you think would be the next steps when you come upon this patient? Okay, call the code stroke standby, very good. And what other things would you do right away? One, keep, what? Neuro assessment you want to do, and you want to document it, because you want to watch if this person's gonna, neuro assessment is gonna trend one way or the other. The other thing you want to try and investigate is the last known well. If we're talking about a hemorrhagic stroke here, but if it was an ischemic stroke, last known well is very important because it sets the clock of when the patient eligibility for TPA begins. So the patient goes to CT because that's all part of our code stroke standby. The rapid response nurse has responded there at the bedside, and because they're now a critically ill patient, rapid response assumes the care of the patient. So they go with the patient down to CT, and almost always when a code stroke is called and the patient's in CT, a radiologist or another physician around will be looking at the scans as they come up so they can see them right away. So somebody has identified there's a bleed on this CAT scan and is calling the hospitalist to let them know. So they come back up to the floor. One other thing that has been done, because it's a code stroke, is teleneuro has been called, especially if they're an inpatient, which this person is. So they're already getting some information. Teleneuro also monitors the scans as they come up, so they're actually viewing the picture, so they know as soon as the radiologist knows that this is a head bleed. For inpatients, we need to secure a bed somewhere. So right away, the teleneurology will be assessing what's available for beds at MGH, because at this point, they'll need a neuro ICU. So when they come up to the floor, back to the floor, the patient is still very acute. He's an ICU level patient at this point. So, you know, for all intensive purposes, the rapid response nurses will stay and care for that patient. And a bed will try to be procured through NSMC Connect. So the hospitalist, as soon as they know, will contact MSNC Connect to get the bed. As a nurse, you're going to be responsible for making sure the chart's all wrapped up. You have all your documentation on what the patient was like before the event happened. And then you also want to make sure you have very clear documentation on your assessments of what the patient was like when you found them. And the rapid response nurses will continue with that and do very detailed neurological assessments. One of the keys of an evaluation in stroke patients is that they can change. And they can change rapidly or they can change very incrementally, but over a shorter period of time, the minor changes can add up. So you want to see where that patient is trending. The hospitalist will do the discharge paperwork, dictate the discharge summary. Many times we see these people, once they get a bed, they either go by ALS or MedFlight, because that's the quickest way to get them to where they need to be. We have these agreements. I think there's only been one time recently we haven't been able to transfer them out quickly. So that's very soothing for us here when we see a patient who's so critically ill that we don't have the capability to handle, that we can move them along to the higher level of care. Any questions on hemorrhagic stroke? Yeah, the question was, will they, can they go right out from the floor to Boston, or do they have to go to the ICU first? If there's any indication that the transfer is going to be delayed, they'll go to the ICU while they wait. If the transfer is going to happen within the next 20 minutes, half hour, that ALS or MedFlight can be there, they'll stay on the floor, because just the, you know, moving them around is just going to take more time than it's going to help. Any other questions? Okay. I'm going to move on to ischemic stroke, and this is what we see generally most of the time here. So an ischemic stroke is when you have the blood supply that's been interrupted in the brain by some type of an obstruction. So it can be either a large vessel stroke, and what I was talking about earlier was the carotid bruit. So the main artery in the neck is getting occluded over time, and sometimes it can totally occlude, which will cause a major stroke because it'll affect a huge portion of the brain. Then we have the small vessel strokes, and usually those are caused by risk factors such as smoking, high blood pressure, bad diet, high lipids. And this is, I like to make the analogy that if you look at the brain in the vessels, you see at the very end, they're getting really tinier and tinier. So these blood vessels that are real tiny are like being hit time and time again with a cigarette, a bad meal, high blood pressure that goes up and down. And finally, they just kind of give up and they just die off. And then a stroke happens at the very end of where those blood vessels end up. And that's the small area of the brain that's get infarcted, and those cells will die. And then we have the cardioembolic strokes. And those strokes are usually resulting from AFib. So when you have AFib, the blood can pool in the heart, and then it gets pumped out into the circulation, and a clot can go from the main circulation up into the brain, and it can occlude, depending on the size of the clot, anywhere along that pathway. Another question for you. The degree of neurological damage that occurs with an ischemic stroke depends on either the location of the lesion, the size of the area that has inadequate perfusion, the amount of collateral flow, or a combination of all those factors. The answer is not A this time. It's D. So we know that large vessel strokes, especially where they're occluded and they affect almost like an entire side of the brain, those are going to be very large strokes because the damaged tissue is much more extensive because a lot more of the circulation has been shut down. And the location also is important because some areas control small areas of the body, while other areas kind of contribute to like an overall function of the body. So the more those areas are affected, the more deficits you're going to see. And then we also talk about collateral blood flow. So people who have risk factors, their body tries to compensate for the blood flow being compromised on again and off again. So they develop collateral circulation. So they grow additional they grow additional vessels from the original ones that were in the brain when they were very young. So if you have a lot of these collateral vessels hanging out, their main blood supply is maybe coming from further down on the blood flow tree. So when the blood flow tree gets clotted off higher up, what is below still has good circulation. So collaterals are very healthy in a bad brain when they're, questioning a stroke. That's why risk factors are so important about being addressed. You don't want to have the blood flow being so compromised, no collateral circulation, especially with young people because they haven't had time yet to develop a lot of collateral circulation. And I'm going to move on to acute treatments for stroke. So we talk all the time about time is brain, which is so important because we know the sooner we can resume the blood flow to the brain cells, those cells which were at risk are not going to die. And when we talk about stroke, we talk about in the brain, when a stroke occurs, you have the area of where blood cells have actually died. So that's like the core of the stroke. And then you have this area around the brain cells that have died, and this is called the penumbra. So these are cells that have been compromised or stunned or just enough so they're not working right, and they still have a chance to recover. So if we can get the blood flow back again, we can't save the dead brains, but we can save the stunned brain. So we can save the penumbra if we treat a stroke aggressively. So the two acute treatments we have for stroke is TPA, which is the clot-busting drug, which if it is a clot that's lodged in there, it'll break up the clot. It'll work on the clotting mechanisms. And then we have the thrombectomies. They do that like in Mass General and Brigham and Women's, where they actually thread a catheter up into the vessel that's occluded. If there's a clot there, they can go in and snag it and resume the blood supply right away. We've had patients here that have had occluded arteries. We sent them into Boston. Now, they would have been really devastated if we kept them here, you know, like totally paralyzed, severe issues with speech. We've sent them into Boston. They've had the thrombectomies, and they go home. So, I mean, this is really impressive what they can do with thrombectomies. But, of course, there's criteria to being able to meet the ability to undergo a thrombectomy. So, first thing is for an anterior circulation, which is the bigger vessels in the front of the brain. They like to get to those patients within 6 hours. That shows the best outcome. But they're doing a whole lot of research now, and they have a lot of studies out there, and patients are always being enrolled for extending that time frame. And they have found that they can do anterior circulation retrievals up to 12 hours that are still very successful. Posterior circulation, because it's a different part of the brain and the circulation and everything, posterior circulation occlusions tend to do better with thrombectomies if they're in a longer time frame. Now they're actually doing up to 24 hours in certain stroke patients, but they need to do a perfusion imaging. And of course, we don't do this here. Again, this is done in Boston, but it's really cool. They can take them into the MRI suite. They can do an MRI of their brain, see what the core area of the brain that has died, and then they can do a perfusion imaging and see what area is still salvageable. So if there's a good mismatch in perfusion to ischemic or dead cells, they have a good chance that that thrombectomy will be successful because there's a lot of brain tissue to save. If there's no mismatch, if it's all the tissue, then there's nothing to save, and they're not a candidate. But this works. I have an IV TPA question for you. The most common side effect of TPA is an allergic reaction, bleeding, severe vomiting, or a second stroke in 6 to 12 hours. The answer is not A, B. I said before, TPA was a clot-busting drug, and it interferes with the clotting pathways in the body. So that's real important to be aware, because what it does is it disrupts the clot, and then it also prevents it from propagating for patients. So the most common is bleeding because you're disrupting that pathway. People can have allergic reactions to TPA. The most common allergic reaction is angioedema, but that happens a very small percentage of the people who get TPA. If a patient has severe vomiting after TPA, that's not an allergic reaction. That's potentially that the patient has bled after receiving TPA, so that's a medical emergency. what you want to do is get a head CT on that patient right away to see if they have a bleed and to see if it needs to be treated. And a second stroke in 6 to 12 hours is very rare, like under 1%. Any questions? Okay. So clinical manifestations or the signs and symptoms of stroke. It all depends on the location of where the stroke has occurred and the size of the stroke. So every part of the brain, I have a little picture here of certain parts of the brain control certain things. The right side controls the left side, and usually some vision, aphasia, speech, and then the left side controls the right side of the body. So it depends on if they have a right-sided stroke, they're going to have left-sided symptoms and vice versa. So they can have any of a number of stroke symptoms, and it all depends on the location where the damage is. And then risk factors, we're always looking at risk factors because as long as we can limit the number of risk factors or eliminate them, that decreases the chance that the patients will have a stroke. So there are a number of risk factors. Some are you're able to change, and others are unchangeable. So things like your age, being a male, being Black or Hispanic, those aren't things you can moderate or change. Things like hypertension, diabetes, obesity, stress, those are things you can act on and get healthier to prevent a stroke. Medical management you want to be aware of because you're going to be monitoring the patient during their medical management, and they might have questions for you also about what's going on and why are they doing this and things like that. So for the medical management piece of it, they do a very thorough history and physical in a neuro exam. They do the head CT non-contrast, CTA, the head and neck. They used to do that pretty routinely, but now with the shortage of the contrast, we're going more towards MRA, and if they can't tolerate an MRA, they'll have carotid ultrasounds done. What we want to see mostly in the CTA is the blood vessels in the neck. If we can get the MRA, then we can see the rest of the vessel imaging of the brain. And you always want to look at the heart because we don't know if an issue with the heart is causing the stroke. We know people with PFOs or bad valves, or if they have some type of endocarditis, they might be throwing clots that are causing a stroke. So you want to make sure they have all their bases covered for testing. Also, so you'll know, and I'm hoping that people have this posted on the floors, but this is a form we developed a few years back. I can pass. And the nurse managers were hanging them by the whiteboards on the patients that saw strokes because it tells you what to expect for a workup and what things are required. So you want to make sure the patient is on an antiplatelet within 24 hours, or there's a reason why they can't be, or if it's not an antiplatelet, some kind of anticoagulant. For patients who come in with a stroke, one of the defense mechanisms of the brain is to elevate the blood pressure to increase the perfusion to the brain around areas that are kind of inflamed and might be resistant to good blood flow. So for the first few days, we allow hypertension, but then we want to have the hypertension addressed to bring it back down to more normal limits. And there's also a 15% per day limit you want to decrease the blood pressure by, because if you decrease it too quickly because you have an area where you have injury, you could run into problems with causing the blood flow to get so low that there's more, the stroke increases in size. We want to make sure that there is VTE prophylaxis, either medication like heparin, enoxaparin, or if they're on warfarin or one of the NOACs, that's fine. If they're not on any of those, they need to be on the boots. People who have stroke patients, I look at the charts every day, and if they're not on boots, the boots aren't documented, they get a call from me, which is a gentle reminder to say, patients need boots, are they applied? And they need to be. This is like a very basic quality of care issue, and this is one of the things that CDC monitors as part of our quality stroke program. We don't need to get dinged on those things that we might not have to get dinged on. And then they also address all the other comorbidities. So they look at what their lipid profile is like. They should have an hemoglobin A1C done so they can be checked for diabetes. They should be on telemetry so they can be looked for any arrhythmias. Lots of patients come in with a stroke, and that's their first symptom of AFib. They've had no other symptoms prior to that. They're on AFib, and if they're in AFib, that's a whole different treatment paradigm than it is if they have a small vessel stroke. For AFib, you want to think about putting them on some kind of anticoagulant or a NOAC if they're a candidate for it. So nursing, nurses are like kind of responsible for making sure the patient gets the whole picture presented to them and that everything they need is wrapped up and coordinated nicely so they get everything they need to have the best outcome. And once they have the best outcomes, their length of stay goes down, their decreased cost. We can really impact these patients by taking good care of them. So in the beginning, like on the floor when you're doing your work, one of the basic things is just to make sure they have a good brain that's perfusing well and they're getting enough oxygen. So the things you do at the beginning when the patient first arrives are really important. You want to make sure that you have the environment addressed so their brain doesn't work too hard. If they have an injury, the brain is going to be working really, really hard to compensate for the areas that aren't working. Plus, it's going to use most of its energy to try and heal the injured brain, and it won't have enough energy or any reserves left over for doing much more. So consequently, most stroke patients are extremely tired, and that's just part of the disease. You want to minimize complications, so you want to be thinking about, their turns and positions, patients with a right-sided stroke or a left-sided stroke, paralysis on one side or the other when you're moving them. Pay attention. The shoulder joint is especially vulnerable to injury because it's so much muscle that controls that joint that it can be easily dislodged. You want to let them do as much as they can for themselves because that just kind of reinforces what they've been doing. So if they can feed themselves, even with like a weekend hand, let them feed themselves because they're going to make that part of the brain work, and it's just going to reinforce that it can do that work. And if the brain has been stunned or a little bit of that area has been affected by the stroke, neuroplasticity will just kick in and get them to feed themselves. It's just like that repetition in the brain. And then communication with some of these patients is a huge deal. Your patients with receptive or expressive aphasia, they can't understand or they can't express themselves. Speech and language has a lot of valuable tools, and they have communication boards that they can give It's very frustrating for them not to be able to either communicate their needs or understand what you want to tell them. And a stroke diagnosis is actually a risky diagnosis. It's one of those low volume, high risk diagnoses. There's only about 5 to 10% of patients in the hospital that have stroke, but it's a high risk. A lot of these people develop complications. They also can deteriorate very rapidly, so if you're not paying attention and keeping an eye on them, they can deteriorate and something might have been able to have been done sooner and you've missed your window of opportunity. They're all at risk for aspiration until they've passed the nurse and swallow screen. Swallowing is muscles in the throat, but it's also a lot of coordination with muscles in the face and the tongue. So there's a lot going on with the swallowing aspect. And different strokes could affect it differently. So until they pass the swallow screen, you have to assume that they are going to have difficulty. So they're MPO until they pass the swallow screen. You may have got my friendly reminders again that they've given something PO and the swallow screen isn't documented. Many times people just forget in the document, when they're documented that it was done. And I get emails back saying, oh, yes, I did it. I know I did it. I always do it. And they go back and they just add it into the record. The other thing I find is that nurses go in and they scan all the meds. They do their assessment, scan all the meds, give the meds to the patient, and go out and do their documentation. So if it's time stamped of when they're doing things, the aphasia screen looks like it was done after the meds were given. Abstractor will look at that chart and said, oh no, they did the screen after they gave the meds. So, the nurses didn't do the screen before. They didn't know the patient was safe. So you'll get friendly emails from me about that too, just to retime it, which is perfectly fine. It's just a documentation issue. Lots of times our patients are at high risk for falls. All stroke patients should be on fall precautions. Patients who are weak because it's a sudden, unexpected event, they forget they have weakness or they think they're stronger than what they are. Patients who have neglect, which they don't even recognize that side of the body as having an issue, will just think it's normal and get out of bed and fall. And if anything ever comes up, changes or a patient falls, and the nurse hasn't reported that to physician, that's on them and they're held liable for that. As nurses, we should all know how at risk these patients are and we should be taking appropriate action. So the initial assessment of the patient, so when they first come on, you want to always assess their mental status, their level of consciousness, see what they have for deficits. You want to look at their pupils, record their size and the reactivity. You want to check for breathing and assess that. And breathing comes in because if patients aspirate and they get aspiration pneumonia, they're going to have trouble with their breathing. You want to always keep an eye on their vital signs and then assess higher function like speech, memory, cognition. We'll have, and it's not infrequently, but we'll have patients admitted with confusion or family members bringing their parents or significant others to the emergency room and say they're very confused, they don't know what's going on. A doctor goes in and does a very thorough exam and realizes, no, they're really not confused. They just don't understand what I'm telling them to do or what I'm asking them. And what's happening is they have aphasia. So always keep that in mind when we're assessing patients. And we do all this monitoring, like I said earlier, to look for trends and subtle changes. The nurses are the expert at finding the trends in neuro changes in their patients. You know the patients the best. Everything gets recorded in Epic, and the Epic design was done. One of the things we made sure we put in there was drop-down boxes for certain categories, so everybody is speaking the same language. So things like motor strength. So motor strength is like a 5-number score. So you actually have a drop-down box for that. So if you say it's a 4 on the right arm, the next nurse coming on, it's very clear what a 4 should be. So if they get a different number than a 4, then they know that's a change, and to keep an eye on it, or to let somebody know that there's a change. That's why that's so important. We always want to keep an eye on their ability to swallow. If things change, make them MPO till we get a nurse and swallow screen, or speech and language sees them. Patients who have had strokes can have difficulty with voiding just because of the muscles involved again. So you want to keep an eye on if they're going to have issues with voiding, urinary retention, or incontinence. And you're going to watch for their mood and behavior too. They've had a stroke. It's many times very devastating to them, very devastating to their family members too, when their family members don't know how to cope. Lots of times they have trouble being supportive of the patient. So when we talk about care of the patient, we kind of like to divide it up into 2 parts. So the first section, the acute phase, is days 1 through 3. So after a stroke has happened, the stroke has happened. If there's no TPA or thrombectomy, it is what it is. The stroke is just going to evolve on its natural course. Those first 3 days are when the penumbra changes. So you're going to see changes with their neuro exam. And that's one of the reasons why we like to let the blood pressure rise for the first 3 days, because all this activity is going on with the brain. And it has limited reserves to start like really healing itself and doing all that neuroplasticity stuff. So it just really needs to be supportive. So I want to keep an eye on that 30% of stroke patients deteriorate within the first 24 hours. That's a good kind of little piece of information to tuck in your brain. We use the neuroflow sheets to document this. Things you want to look for, again, are the level of consciousness, their speech quality, muscle tone, any involuntary or voluntary movements, especially if they're paralyzed on one side. You want to see if they have any movement at all. And sometimes it can be so subtle, they're not even trying to move. The muscle just kind of responds like it's trying to wake itself up. And you want to make sure you're giving the DVT prophylaxis. You're also going to watch for their eyes and keep an eye on that. Changes in pupil size can indicate increased intracranial pressure, which means that the stroke is rather big and it's pressing on something it shouldn't be. You want to watch for their temperature. We never want stroke patients to get a temp, because that makes the brain work much harder, and it compromises their whole ability to heal, and it sets them up for a whole range of other complications. You're going to watch their eye and nose. You're going to watch for signs and symptoms of bleeding, especially if they've gotten TPA. That's really important. But even if they've been started on warfarin or a NOAC because they've discovered AFib, or they have a history of AFib that was never treated, or, you know, people who might be more sensitive than not to like going on aspirin and Plavix at the same time, they're at risk also. And then you want to keep an eye on their lab work. The physicians are responsible for ordering them, but you want to make sure that you know they need to be ordered so you can follow up on them. Post-acute phase, that's after that first 1 to 3 days. So you're going to continue on with your monitoring, but you're going to kind of notice that unless they have a really huge stroke, they kind of plateau on their exam, and you're not going to see any wide fluctuations anymore like you did within the first 3 days. By now, we want to start drilling down that blood pressure back to a more normal level. If patients have had hypertension, untreated hypertension for a long time, that could be really challenging. And they might have to finally address it in the hospital start, but then do the follow-up on an outpatient basis to really get their blood pressure under control. But as long as they're on something so they're trending in the right direction, that's okay. And you're going to continue to work on making sure that you don't set the patient up for any other complications. You want to turn them, you want to get them out of bed. If they can get moving, the sooner the better, up walking around. Again, it's whatever the patient can do to keep the brain in the mode, you know, the more you can do, the more you can do is kind of thing with stroke. And you don't want any of the pathways that might be affected a little bit to really get shut down, because then they'll have to like train their brain to do that again. Some of the possibilities you can see with these patients, they could have vision problems. They can have apraxia, where they know what they want to do, but they can't do it. They can have neglect. They can have, again, the cognitive and behavioral changes. If the frontal lobe is affected, they can have problems with the filter being gone. So we see a lot of that. The motor defects and the elimination disorders we'll see out of their deficits. We want to make sure we educate our patients on all the healthy ways of living to prevent a second stroke or subsequent stroke. So as part of your teaching, you'll want to address all those, and that's in the patient education and EPIC that's done, and then also as part of the AVS that you give your patients. Coordination of care, that's really important because it's a team effort to take care of these patients in the hospital. It involves medicine, nursing, PT, OT, speech, radiology, lab. It seems like everybody touches the patient in some form of another. So, and nurses are the one at the bedside making sure kind of everything runs smoothly. And we know, again, that 33% of stroke patients have long-term disabilities and 20% go to long-term care. So whatever the nurses can do at the bedside is just going to help the patient in the long run. A few pearls I found. Time is brain. We teach patients a fast approach so they can identify stroke symptoms for themselves or others and act on them. Stroke is a non-head CT, so code stroke, head CT, always. The TPA within the magical 4.5 hours, the thrombectomy, if they're a candidate for it. And just a note about primary prevention, we do a lot of education, so even if a patient comes in with a TIA and hasn't had a stroke yet, they're still in the primary prevention mode. The research has shown, which I have a hard time wrapping my brain around, that 80% of all strokes can be prevented. So enormous to me. But if we can do that, let's try. And, you know, addressing all the things we address with our patients even after they've had a stroke are important. And then inpatient strokes. I have another case study for you. So in the hospital, we don't teach FAST anymore. We've gone to the BFAST because strokes also can affect balance. So we see a lot of dizzy patients come in who roll in for a posterior circulation stroke. And then vision. So people who have blurred vision or nystagmus or something going on. So eyes is in that. So we do the BFAST. So we have a 72-year-old white female who presents to the ED complaining of palpitations and mild left upper and lower extremity weakness. In the ED, she's noted to be an AFib. Admitted for newly diagnosed AFib and a stroke workup. Her MRI overnight is positive for a right-sided infarct. Next morning, you come into the room around 10 o'clock, and now you know the patient has slurred speech. What are you going to do next? Stroke standby, last known well, and the hospitalist is going to respond. Do you think this could be a new stroke or part of the old stroke? What? No. Somebody just mentioned take a blood thinner. We don't. Oh, blood sugar. I'm sorry. I thought you said blood thinner. No, blood sugar. Yes. How that? A little nervous up here, TJ. And check the blood glucose because hyper and hypoglycemia can mimic stroke symptoms. So would this be, would you think, a new stroke or an old stroke? Or an evolution? All right, it actually is a new stroke. And it's a new stroke because it's affecting the part of the brain that handles your communication. So it's affecting the Broca's area, whereas the weakness part of the brain is the motor cortex, so that's a different area. So you have a code stroke situation now. So you want to see what's going on with the patient. So they're definitely going to get a CAT scan because it's not just the brain acting funky and just making the symptoms worse and better the first day. It's actually a brand new symptom. The other thing you also want to check out is the last known well time, because this is a new stroke. So you want to know when the last known well time is. Because if you think about it, a patient who has AFib can be throwing clots all over the place and not know it. If it's disabling enough, they will do a thrombectomy on a patient just because they have global aphasia. So even though they wouldn't be a candidate for TPA because they've just had a stroke, they might be a candidate for a thrombectomy and to be med-flighted or ALS into Boston for that. If they're in the ED, be transferred directly to an OR suite. We do have a program with Mass General for these kind of patients who have clots that it's a just say yes. So the fellow at MGH will say, yes, this is a thrombectomy candidate, get them ready and send them. We don't need a bed, we don't need an attending, we just book the next med flight or the next ALS. For these patients, they go right to the top of the list for med flight, and usually within 20 minutes, they're off the floor and into Boston. We've had excellent results with these patients. Now, if this wasn't a person, if say her MRI was negative overnight, hasn't had a stroke, do you think the treatment plan would change? You would do absolutely the same things. The thing that would change here is now she's a candidate for TPA. Because her exclusion for TPA was she just had a stroke. So you don't want to give a clot-busting drug to a patient who just had a stroke because they might bleed into that damaged portion of the brain. Since there is no stroke, candidate for TPA. What happens in this case, and we had it happen a month ago with the patient who had stroke symptoms. Nurse evaluated her, hospitals evaluated her, felt she was a candidate for TPA, went down for her CAT scan of the head. Neurology was called right away. They looked at the scans, and after they did her scans, it's like, yeah, she's a candidate for TPA. So part of our code stroke standby and code stroke process is if they are a candidate for TPA, rather than going back to the unit they came from, they're going to go right to the ICU. TPA can only be given in the ED and the ICU. So this patient went from CAT scan to the ICU. So as you can imagine, there's coordination and handoff and reports going on here. But the patient was deemed a candidate, they got consent, and she received TPA. So, and after like 3 days, she had minimal symptoms. And she had pretty much almost plegic on one side, I guess, when they first found her. So she did really well. But this is like the kind of impact nursing can make. And there are different pathways and ways to go when you come upon a patient with new stroke symptoms. So you always want to be aware of making sure you do your assessments and proactive with the patient. If you're ever concerned that it might be a stroke or it might not be and you're really not sure, call it. Go with your gut. Nurses' guts are fabulous. If they think there might be a stroke going on here, most times they're right. If not, it's a stroke mimic that you wouldn't be able to tell, and lots of people can't tell. Like the patient has had a seizure and they have some residual paralysis after the seizure. People coming upon that patient after the seizure is completed are never going to know what's going on, and it looks like a stroke. So always err on the side of calling code stroke standbys. And we monitor that too. So we look making sure that when you call it, the process went right. If there were any problems, we know about it. We can address it. If people have questions, that can be addressed in the debrief. So it's really important. Anybody else have any other questions? Questions in the chat? Okay. This is what the code stroke standby and code stroke algorithm looks like. It's very comprehensive. It's in the teleneurology reference books at every nurse's station and on the code cards. These are my references. Actually, we have a brand new reference out from 2021 for the nursing care. The best up-to-date information. The last one came out in 2009. That's it. Well, thank you.
Thank you, Eileen. For those of you on the online, you will be sent an email with your evaluation, and then for those that stayed on for the whole time, you'll get your your contact hours virtually after you complete the evaluation. Thank you.